Welcome to the workshop, Ask the Experts, Questions About Transplants Using Your Own Cells and Autologous Transplants. My name is Michaela O'Brien, and I will be your moderator for this workshop. It's my pleasure this morning to introduce you to today's expert panelists, Dr. Adrienne Phillips, Dr. Amir Steinberg, and Dr. David Vesole. Dr. Adrienne Phillips is an associate professor of clinical medicine at Weill Cornell Medical College and associate attending physician at the New York-Presbyterian Hospital. She cares for patients with all types of blood cancers and a special interest in treating lymphoma patients who need a stem cell transplant. Dr. Amir Steinberg is the clinical director of adult stem cell transplantation at Westchester Medical Center, where he focuses on the treatment of patients with blood cancers. He's also actively involved in FACT, the Foundation for Accreditation of Cellular Therapy, and is co-chair of FACT's Performance Improvement Committee. Dr. David Vesole is professor of medicine and director of the myeloma program at MedStar Georgetown University. He is also professor of medicine and co-director of the myeloma division and the director of myeloma research at the John Theurer Cancer Center at Hackensack Meridian School of Medicine. He's an internally recognized expert in multiple myeloma. Dr. Vesole currently serves on the Scientific Advisory Committee and the International Myeloma Working Group of the International Myeloma Foundation. Dr. Vesole is also a member of the Blood and Marrow Transplant Clinical Trials Network Multiple Myeloma Protocol Committee, the ECOG Blood and Marrow Transplant, Lymphoma, and Multiple Myeloma Core Communities, and is an inspector for the Foundation for the Accreditation of Cellular Therapies, FACT. So now let's begin. Our first question is, what are the pros and cons of purging stem cells before an autologous transplant for myeloma?
Oh, okay. I think that one's for me. Thank you, Michaela, for the introduction, and I'd just like to briefly thank the Blood and Marrow Transplant Information Network for organizing this wonderful symposium. So the question is about purging stem cells for autologous transplant, and that's a good question. The concern is that we're collecting your own stem cells. Frequently, these blood cancers start in the bone marrow, so there's a theoretical concern that there could be contamination by a cancer cell, whether it's leukemia, lymphoma, or myeloma, in the cells that we're collecting. And these days we have pretty sensitive flow cytometry testing where we can really just isolate the CD34 positive stem cell. So what we do here at Cornell, we usually do bone marrow biopsies and aspirates before doing an autologous transplant to make sure, at least for those with lymphoma, that there's no myelodysplastic syndrome and someone who's heavily pretreated or no blood cancer. We can send flow cytometry to make sure there's no cancer cell in the cells we collect. And then our stem cell lab can also really select for the CD34 positive stem cell. So we feel that we're not giving back any cancerous cell in the product. I'm not sure if any of the other experts want to comment on that question as well.
Yeah, I would like to. This is David Vesole, and I also want to thank the BMT InfoNet. Being probably significantly older than my esteemed colleagues, I've been involved back in the early 90s. They actually had technologies that were attempted to purge or clean up marrows. We were using marrows at that time. It would be applicable to stem cells, which is what we use now. And there was chemotherapy purging with a modification of cyclophosphamide, which most of my colleagues are well aware of. Doing 4-HC purging, that just resulted in just destroying stem cells as well as getting rid of bad cells. But there was actually ways, as Dr. Phillips mentioned, of isolating out CD34 positive cells using either flow cytometry or high-speed centrifugation. Bottom line is, yes, you have myeloma cells in your peripheral blood when we collect them. at least in the older days. Now with much more potent induction therapies, that may be less likely. But when we did have cells that were in the bone marrow or in the bloodstream, and we did try to clean them up, we could clean them up to 99.9999%, but the patients relapsed at the same rate as they did, even if they didn't get cleaned up cells. This is a study that was published back in the 90s, meaning that it's probably not the few cells that you have in your peripheral blood that set up and colonize again. It's that we didn't have effective therapies to eradicate, even with the stem cell transplant, eradicate any residual myeloma cells at that time.
Dr. Steinberg, are there genetic abnormalities that cause someone to get multiple myeloma?
By the way, thank you as well to the, Dr. Phillips alluded to. Thanks so much for inviting us to participate in this endeavor. It's a great meeting. Regarding multiple myeloma, any genetic abnormalities, as far as I'm aware, there are not any kind of genetic abnormalities or conditions that can lead to an increased risk of myeloma. With multiple myeloma, we do see chromosome abnormalities that can be associated with the condition itself, but no one's, let's say, walking around, say, born typically with those conditions and then guaranteed to get the multiple myeloma. There are, ethnic groups at higher risk of myeloma, but not genetic disorders.
Okay, Dr. Phillips, how long does frozen stem cells remain viable?
I think you skipped Dr. Vesole.
Oh, okay, yes.
We're going in order. I just want to give them the opportunity to have the first shot.
Dr. Vesole, how long do frozen stem cells remain viable?
So that's a great question. So we recently published a paper where we looked at stem cells that have been frozen for over 10 years, including some that have been frozen for over 20 years. This is stem cells in general, may not have been specifically for myeloma, could have been for lymphoma or some other hematologic condition. And we found that even after 20 years, the cells were viable, that they were able to repopulate and perform the regeneration of the bone marrow which was actually the indication for those cells. So they are essentially, given the correct breathing technologies, they are good forever.
Great. Okay, now Dr. Phillips, is there usually an age limit or a second stem cell transplant for amyloidosis?
So that's an interesting question. We don't have, at least here at Cornell, a specific age cutoff. We can talk about chronologic age, which is the number, how old you are, but we also consider more physiologic age, and we look at your comorbidities and your end organ function. So I don't like to say that there's a specific cutoff where we would exclude anyone from an autologous transplant. If the question's about a second transplant, I think that's even less known. But I don't want to put a number on it because we've certainly had some patients that are well above 70 and have no comorbidities and have a good performance status, and we would hate to turn them away from a transplant just based on a number.
Okay. Dr. Steinberg, are there any markers for a myeloma relapse?
Yeah, so when we follow patients for multiple myeloma, we'll typically follow their proteins in the blood, the monoclonal proteins, the IgG, IgA, kappa, lambda. So those are going to be the markers that we keep an eye on with visits after someone has had a stem cell transfer for myeloma. They are starting to look at minimal residual disease testing or just ultra sophisticated sensitive test to maybe catch the myeloma even earlier if it's starting to come back. Though we're still trying to figure out how to best utilize that particular test.
Okay, here's a question for Dr. Vesole. Do myeloma patients often have trouble multitasking 5 years after their transplant? My husband seems to focus very well on one item at a time, but only one. Is this related to transplant or his age? He's 76 now.
So that's an unfortunate scenario, I'm sure, to see and very, very difficult to deal with. But the myeloma itself doesn't cause this type of activity, that's for certain. And yes, you know, there's this issue of chemo brain, which not related strictly to just myeloma. They talk about it with all kinds of diseases, beginning chemotherapy, whether you get chemo brain, but chemo brain is really a non-specific entity. This individual really should have neural behavior testing to see if he's got evidence of progressive cognitive dysfunction. I don't think it has anything to do with his transplant at this point in time, and it has nothing to do with his myeloma. He really needs to be formally evaluated by a neurobehavioral specialist.
Thank you. Dr. Phillips, could my hair loss be connected to multiple myeloma? Are there any treatment options beyond the traditional recommendations?
So hair loss due to multiple myeloma, the condition I'm not aware of, but certainly many of the treatments that you could have had to treat the myeloma could cause hair loss, particularly chemotherapy. So I would say in my experience, the multiple myeloma itself does not cause hair loss, but certainly treatments for it can.
Okay, Dr. Steinberg, this is a question about sweating. This patient had an auto transplant from mantle cell lymphoma in 2022, and they didn't sweat in the beginning, and now there's a little bit of sweating, but when there's sweat, there's irritation. There's no hair under their arms. What causes this, and are there any treatments?
Yes, I saw that question as a preview, and I was trying to look into this, and I don't have any scientific explanation I can think of specifically for this. But in general, chemotherapy, and the more powerful the chemo, the more it could potentially affect any of our glands, whether that's salivary glands, you know, to help us. That's why some people get a lot of dry mouth after chemotherapy. And it can also sometimes affect our sweat glands as well, or, you know, our hair follicles. And the hair follicles and sweat glands are intimately related. They're to each other. And so sometimes if, for example, you don't have a lot of sweat, you're going to have potentially itchiness in that area because the area is going to be dry, and dry skin tends to lend itself to, you know, feeling that sense of itchiness. So I think with time, as time goes by, our body tends to heal in terms of the salivary glands, sweat glands, hair follicles, and hopefully that'll improve over the duration. I don't know if anyone else has any experience, my colleagues, with this phenomenon.
I'm glad you got asked that question, not me.
All right. Here,
yeah, I saw the preview too, and I haven't had that experience. But sometimes in donor transplants, when you develop chronic graft versus host disease, if you've had a donor transplant, you can definitely see skin changes. And I've had one or two patients comment on their ability to sweat related to chronic graft versus host disease, but that's not typically something I've heard patients complain about using their own stem cells.
Dr. Vesole, can you please explain more about bile salt diarrhea and the mechanism of action? Is it relatively rare or just new? This patient has had multiple myeloma for 8 years and only recently heard of this term. For 5 of those years, they've been struggling with diarrhea as a side effect from Revlimid.
So Revlimid absolutely can cause diarrhea. The incidence of Revlimid, if you actually look at the original studies, it's about 42% of the patients, 45% of the patients have diarrhea from Revlimid, and about actually 25% of the patients have constipation, and there's a few that alternate between the two. Revlimid-induced diarrhea, I'm not sure I know the mechanism of why that happens. We have to exclude that there's some other etiology besides the Revlimid So I often give patients, if they're, in remission, stable, so forth and so on, I'll give them a month off and see if their bowels, get back to normal, because that's more than enough time for any abnormalities in the bowel and the gut flora to regenerate in a month, and see if the diarrhea goes away. If the diarrhea doesn't go away, then the patient needs to be worked up for non-Revlimid-associated diarrhea. Managing the diarrhea is somewhat challenging. Usually you can get by with low doses of motility inhibitors such as Imodium or Lamodal. A few of our patients, we use cholestyramine or Questran or Colestipol to try to control the diarrhea. And the other thing that always should be considered if you're really convinced that the Revlimid-associated diarrhea is dose reduce the Revlimid. If it's for treatment purposes, the standard dose is 25 milligrams. If it's for maintenance, it's 10 milligrams. But there are many other doses available of Revlimid. It comes in 25, 20, 15, 10, 5, and 2.5 milligram doses. And usually you can find a symbiosis of Revlimid and the stool volumes with that are caused from the diarrhea from the Revlimid.
Here's another GI question, Dr. Phillips. When amyloid is found throughout the GI tract, does it remain after stem cell transplant, and can it compromise absorption? This patient's main concern is recent weight loss.
So similar to what Dr. Vesole said, I think, we should, if you're still having weight loss, you should be evaluated for any other causes. But transplants in amyloid really can take a long time to reverse what I'm calling end organ damage. So amyloid is a disease that can impact multiple organs, and when you undergo a transplant, those cells will stop producing amyloid first, so you won't have any additional amyloid deposition in the organs that are involved. But it takes time for that amyloid deposition to resorb and for organ function to improve. So I would say, certainly depending on when the transplant was, you could continue to have problems with your GI tract if that's where the amyloid was deposited. But I would also worry about alternate explanations.
Okay, Dr. Steinberg, where can I find a list of maintenance therapies for multiple myeloma currently approved by the FDA, including their efficacy and risks?
Yeah, it's a great question. I think a good resource, and something that I use as a clinician physician, is the NCCN, National Comprehensive Cancer Network, nccn.org. And I don't know, I don't believe they have any restrictions if anyone wants to look at those guidelines. Typically, though, it's something that physicians use. And again, I happened to look last night. There is a section there on maintenance treatments. There's a list of the available maintenance treatments that one could use. And the NCCN.org section on multiple myeloma also has a lot of information on all the details of efficacy and how well those maintenance treatments perform. So it's free as well. It's free to sign up and log in. And I don't think you necessarily have to be a clinician to sign up. I don't think they're going to restrict you from doing that.
No, so anybody can sign up, but the specific answer is only lenalidomide Revlimid is approved for maintenance by the FDA. There are other options, as Dr. Steinberg mentioned, that the experts in myeloma have pooled their resources and said that these are other considerations, but the specific answer to the question is only lenalidomide Revlimid is approved for maintenance therapy.
Great point. I mean, they list, for example, on NCCN daratumumab or tezimib or Vesole, but thanks for bringing that up.
Yeah.
Official. Yeah.
Exacimib, blah, blah, blah. In the future, just for people that are interested, there's 2 international trials using the monoclonal antibody called daratumumab with or without Revlimid for maintenance therapy after transplant. Both those trials have met their accrual. One of them just met their accrual 2 days ago. and those trials are going to change the maintenance therapy algorithm, and then almost certainly in the future, probably 2-3 years from now, it's going to be a combination of daratumumab, the trade name for that Darzalex, plus Revlimid is going to be considered standard of care.
Dr. Vesole, how many folks are post-transplant are being treated with IVIG to boost their immune system after hyper-CVAD and Rexaton stem cell treatment? What are you learning about this with long-term follow-up studies?
So this is a difficult question to answer because this is probably a question for I'm going to assume it's for either mantle cell lymphoma or acute lymphoblastic leukemia. This is not a myeloma regimen that's used. So I don't know if this person had an allogeneic transplant or an autologous transplant, which also confuses the issue. But the answer is that a lot of the people have compromised immune systems post-transplant, no matter what their hematologic disorder is. We do not routinely treat anyone with IVIG, intravenous immunoglobulin, unless their total IgG level is less than 400 milligrams. And then we would, in that situation, for select individuals, and it's not uniform, and I can ask my full-time transplant colleagues to comment on this more thoroughly than myself. But we generally use this for people that have repeated infections, not just based on the IgG alone. But the insurance companies generally will not pay for IVIG, which you can actually, many insurance companies actually encourage you to do that at home, unless that level's less than 400. But I'm going to defer to my colleagues about their thoughts about IVIG.
I would agree. I primarily use it in donor transplanted patients, so allogeneic patients who have low immunoglobulin levels and recurrent infections.
I've sometimes had myeloma patients who, you're monitoring their immunoglobulins post, after the transplant, and they're going to have frequent infections periodically, and so then I'll check. Sometimes I may add immunoglobulin. It's for those under 400 who have those infections.
Okay, Dr. Phillips, do you need to be revaccinated after CAR T therapy and also revaccinated for Shingrix and COVID? The baby vaccines after CAR T for myeloma, is that needed again also?
So that's a great question. So our practice here at Cornell is to revaccinate patients after CAR T. We usually rate between 4 and 6 months. But it really depends on, their immune system's reconstitution. Vaccines are a great way to try and prevent infections, but frequently in patients with blood cancers who've had a lot of treatment, whose immune systems continue to be suppressed, sometimes, patients can't mount a response to certain vaccines, and this has certainly become an issue during COVID. But the question, as I now am answering it, if it was specifically about CAR T, we do revaccinate CAR T patients between 4 and 6 months after. But I would say it also depends on the patient, whether their disease remains in remission, whether they're on any maintenance treatments, and how strong their immune system is to kind of gauge the degree of whether that revaccination is going to be effective.
Right.
So in our practice, we're actually checking titers at 3 and 6 months post-transplant.
I was going to add that too. Thank you.
And then we're deciding based on which of their vaccines are still effective, which ones we're going to restart. Regarding COVID, the CDC just revised guidelines about 4 days ago, and they say that patients who are immune compromised, which essentially all of our patients are immune compromised, they can actually get vaccines now every COVID vaccine, bivalent, every 2 months. We haven't decided as a group whether we think that I don't know what that's based on. They didn't give us any data to support an every 2-month vaccine schedule. And for individuals over 65, they recommend the repeat vaccines every 4 months. So again, no data to support where they came up with that recommendation, but these are the new CDC guidelines. So immune-compromised patients of any age every 2 months, and for individuals over 65, even if they're not immunocompromised, that they can get revaccinated for COVID.
I think this is a question for all of you. This patient had a transplant for multiple myeloma in 2021. My M spike has consistently been around 3 for the last 14 months. Would you recommend a second transplant? And is it too soon for a second transplant?
I think this is a very individualized question that we have to know the whole context of what's going on with the patient. I will say that the patient asked me yesterday about that he had enough stem cells collected for another transplant, and I would say that that there's more and more new treatments coming out these days, and I would say the use of a second transplant is becoming less frequent. There is a role for it here and there, but with all the new treatments, I would say it's, again, hard to know about this individual situation, whether there's other therapies that might potentially be offered as opposed to a second transplant.
I'll let Dr. take a shot at this. The expert here, I think, in myeloma and transplant.
So this is I'm going to pull another age one on my colleagues. So I was actually part of the original Arkansas team back in the 90s, where we looked at the time interval between first and second transplant. And we found that the optimal time, if you're going to do a tandem autologous transplant, is less than 6 months. So given the fact that this particular individual is at 14 months, that is not something I would consider. And it sounds like they're stable. I'm not sure what the benefit would be anyway, but again, as Dr. Steinberg alluded to, we don't really have enough details on an individual to know what it was before, what's going on now, or anything like that. So I can't comment on that specific individual. But for those individuals that tandem transplants considered, which we still in our practice consider for patients with high-risk myeloma based on their cytogenetic configuration of their disease, we try to do the tandem transplant within the 6-month time period.
Dr. Vesole, this patient is having an auto transplant in May for multiple myeloma. They want to know if their stem cells will be purged and cleaned before being put back into their body. If not, what's the chance of myeloma cells being put back into my body?
Yeah, so we already addressed that earlier. The answer is, part of that has to do with how good a remission the patient's in right now. For example, if they are MRD negative, minimal residual disease negative, then we probably are giving few, if any, myeloma cells, because if they're MRD negative, it means you can't detect any. But in the absence of MRD negativity, almost certainly there are some myeloma cells in the stem cell product. And no, as we talked about with one of the first questions, there is no active purging or cleaning up myeloma cells anywhere that I'm aware of in the U.S. or in the world, actually.
Right, Dr. Phillips, this patient had an auto transplant for an autoimmune disease, myasthenia gravis. Does most of the information from this conference about all the possible late effects on transplant apply to stem cell transplant for autoimmune diseases as well?
So that's a great question. The indications for autologous transplant for autoimmune disease are few and far between. There are only a few centers. We don't do that here at Weill Cornell. I think they used to do it in Chicago and perhaps at Duke. But certainly some of the long-term effects, you've gotten high-dose chemotherapy and your stem cells, so your count should be monitored. You can have, prolonged low counts and a risk for MDS, but, the risk of relapse is definitely going to be different, and I'm less familiar with kind of the neurologic sequelae of myasthenia gravis, so I'm not sure what, long-term effects could be in that organ system.
I was, a couple of years ago, I had a couple of myasthenia gravis patients referred to me, so I was reading up a lot on the chemo that they do get, and you alluded to Chicago, and the most common regimen for these rheumatologic or autoimmune diseases is usually less intense than maybe, say, myeloma or lymphoma. You could still have all the risks that Dr. Phillips mentioned, but maybe slightly less toxicity in the long run, but still exists.
Okay, Dr. Steinberg, how low should IgG be allowed to go before infusion?
In terms of repleting it, I usually the number 400 is what I kind of use as a cutoff, and guidelines that were published, I believe maybe even now 11, 12 years ago, use that number. They haven't been updated. It's kind of infectious disease complications after transplant and how to prevent them. It was that was the cutoff number, 400.
Okay, here's a question about rituximab. Or rituximab, sorry. My rituximab maintenance therapy does not allow me to get the COVID vaccine because it would be ineffective. Yet I'm still getting all my other routine vaccines. How does the patient know if those vaccines are effective in the presence of rituximab?
So it's my turn. So that's a great question, and my guess is that none of the vaccines probably work if they already proved that the COVID vaccine doesn't work. But it's simple enough. You can test titers against pneumonia. You can test titers against shingles. You can test the blood tests, and you can find out if the vaccines are effective or not. But the patients who are really compromised, those that have chronic graft-versus-host disease, those that have rituximab maintenance, those after at least shortly after CAR T cells, their immune systems really are not capable of being immunized. But there are certainly laboratory tests that you can prove or disprove whether the vaccines are effective.
Thank you. Dr. Phillips, is male breast tenderness a side effect of an auto transplant? I had mantle cell lymphoma.
No, I'm not aware of that as a side effect.
Okay. Here's a question about CAR T. I'm going to ask. Oh, Dr. Steinberg?
Sorry, the only thing I could think of with that is if it affects testosterone, or sometimes if there's you can sometimes get, I guess, gynecomastia with a decrease in testosterone after high-dose chemo. So maybe worthwhile checking that level, or it could be just also a natural phenomenon, but worthwhile checking testosterone.
This is a CAR T cell therapy question for any of you to answer. What are the options if CAR T for myeloma stops working within or after the year of ABE-CMA was given? Dr. Vesole?
I probably should take this one. So Abecma is one of the two CAR T cell products that are commercially approved for myeloma, and CAR T cells are certainly an effective therapy, and they're approved for patients who've had 4 or more lines of therapy, meaning you've had at least 4 different alphabet soups. And so these are fairly heavily pretreated patients that have had disease for usually quite some period of time. And yes, you can try to do CAR T cells, as my colleagues will probably tell you. Not all these patients are able to manufacture CAR T cells, but if they are, that's certainly a very good option for patients with myeloma. Unfortunately, we still don't think that CAR T cells are curing patients with myeloma, unlike large cell lymphoma, where the cure rate somewhere in the 30 to 35% range based on the most recent long-term follow-up in diffuse large B-cell lymphoma. After CAR T-cell therapy, if you've already had 4 more alphabet soups beforehand, it does become a bit challenging about what therapies are available. I will tell you that in the not too distant future, we're going to have a new Revlimid-like drug that's called iberdomide, and we're going to have another bispecific antibody. It's called talquetamab. It depends on how long after they had the abecma that they've disease progressed, because if it's been a long period of time, they could potentially get another BCMA-targeted therapy. Drug got approved last October, called a bispecific antibody called teclistamab, which will work for some patients even if they've had a previous CAR T cell. But the number of options really becomes dwindling after you've had 4 more lines of therapy and a CAR T cell, but it's not completely depleted, and there are things that can be done for those individuals.
Okay. Dr. Phillips, can constipation that is common during chemo and transplant continue long afterward and become a more regular problem?
So yeah, constipation is super common going through transplant, getting chemotherapy, particularly with certain chemotherapeutic agents. In my experience, patients actually, though, have more problems with diarrhea, at least in the first 2 weeks or month after a transplant. And I would say if it's prolonged, as Dr. Vesole mentioned on another question, you should probably be evaluated with a colonoscopy to make sure it's not infectious source of sorry, I got confused. You were talking about constipation. Sorry, I was talking about diarrhea. The question's about constipation. I would still, though, have a colonoscopy to make sure that there's nothing obstructing and no alternate etiology for constipation, but it can happen. Certainly also if your diet has changed.
All right, here's another question, Dr. Steinberg, a GI question. Is small intestine bacterial overgrowth common in an autologous transplant for survivors?
Yeah, great question. They've looked at this more, the different kinds of bacteria that grow in the gut, more in the allogeneic transplant setting or the donor type of transplant. But I would say that you're going to have, with the chemotherapy that you're getting, you're going to be killing cells in the gut. You're also going to be getting antibiotics during your hospital stay, and that's going to be killing bacteria in the gut. And some of those antibiotics to prevent infection have been sometimes associated with growth of certain bad bacteria, such as C. diff or Clostridium difficile. So there are definitely going to be changes in the gut. Overgrowth, it depends on, for example, is that bad bacteria overgrowing? Then you're going to have symptoms of diarrhea. Could you have overgrowth that doesn't cause those symptoms? I would say that's within the realm of possibility as well.
Dr. Vesole, in your experience, can an autoimmune disease, IgG4 or other disease, emerge years after an auto transplant for non-Hodgkin's lymphoma as a result of the transplant?
That's an interesting question, and honestly, I don't know that. I've been doing transplants literally for 35 years, and I don't know that I ever saw a patient that I thought there was a definite cause and effect of autoimmune disease associated years previously from an autologous transplant, but I'm going to defer to my transplant colleagues and see if they have seen something like this. If it happens, it's got to be extraordinarily rare.
I have not seen that.
I will say I've seen autoimmune diseases occur after allogeneic transplants. That they actually have. I've seen that the patients, again, not commonly, have inherited, if you will, the autoimmune disease that their donors had. But I haven't seen that kind of phenomenon in patients who've had autologous transplants.
Okay, here's a question for all of you. I think it's that this patient's been treated for multiple myeloma and their providers have treated them well. They responded to RVDD therapy. However, they were diagnosed in 2022 with lesions that covered 80% of their sacrum. And they also had these lesions in their lumbar spine. They were unable to walk due to the pain. And the doctors haven't really addressed the pain as it's still continuing for me. I can't walk very far and my gait is unstable. Can you address pain and ability to regain strength? Dr. Phillips.
So it sounds like the symptoms have been going on for a long time. So I guess you would need imaging to see, how things have responded. And I would probably see a neurologist to make sure, we're not missing anything else with what's going on. But I would say, I guess, after treatment, pain should get better. It might not always go away.
Well,
Okay.
I was just going to say,
Dr. Steinberg.
Just another thought or idea as well is sometimes when I'm perplexed about someone's pain or their musculoskeletal issues, I will sometimes refer to physiatrists, physical medicine rehabilitation doctors. They're kind of these underrated specialty, but I've really found them they to think outside the box. They're very good at that and can really help patients sometimes. So that's something to consider as well.
Okay.
So throwing in my 2 cents worth, people with chronic pain need to see a pain and palliative care specialist. It's not something that, like Dr. Phillips mentioned, if there's something that's correctable, then that is something that should be pursued. But if it's something that's just chronic pain, that there's no procedure that can be done to relieve those symptoms, then that individual needs to see a pain and palliative care specialist. Because they sometimes, and there's 2 different types of pain and palliative care. There are those that just give medications, and there are those that actually do procedures. And usually you don't find this both one individual doing both. Everyone's so super specialized. But potentially chronic pain, if it's not something that can be corrected, potentially a nerve block might be appropriate, or some other type of intervention by a pain specialist that may help alleviate some of these symptoms. But you do have to go through the procedure, making sure there's nothing there, just like Dr. Phillips mentioned. They may need further imaging, they may need to see a neurologist, and if there's nothing that looks like, they may need to see a surgeon, and if there's nothing that looks like it's correctable, then the ultimate person to manage chronic pain is a pain and palliative care specialist.
Thank you. Could the panel comment on efficacy duration with axi-cell follicular lymphoma treatment? Dr. Vesole.
Yeah, I actually can't comment on that because it's a lymphoma question. So I'm going to defer to Dr. Steinberg and Dr. Phillips.
Yeah, I can comment on that, I guess. So the studies have certainly shown very high response rates for axi-cell in follicular lymphoma, as high as 70%. I think the concern is we don't know the duration of these responses. So unlike large cell lymphoma, where CAR T has prolonged data, for follicular lymphoma, which is I think what the question is about, the response rates are high, and I think we just need to follow the data a little bit longer to see the duration and its maximum effect. But it's very promising.
Okay. Dr. Steinberg, for patients having monthly IVIG, should levels of immunoglobulins be within normal levels just prior to the next infusion?
If you have the wherewithal, to check the labs, then ideally yes. Because even after one infusion, the numbers can sometimes bump up to adequate levels, and then you might be exposing someone to additional treatment that maybe they don't necessarily need to have. But I've seen levels recover even that's after one treatment, so it's worthwhile checking.
Okay, Dr. Vesole, this is another IVIG question. This patient is going to have a hip replacement, and they have monthly IVIG infusions, and her next appointment is 10 days before the surgery. Would you recommend that that's okay?
Yeah, so we don't know why they're getting IVIG for extended period of time. But bottom line is IVIG, besides the fact it takes the time to administer it, is a benign protein infusion that there's no reason that giving it 10 days before should give them pretty high levels during their surgical procedure if it's meant to be for some type of bacterial prophylaxis, and that would be absolutely fine.
Okay, this is a question. Dr. Phillips, have you heard of GVHD of the tympanic membrane or of the white matter of the brain?
I have rarely heard of GVH involving the brain in, again, allogeneic transplanted patients. So the topic of this symposium right now is autologous transplant. I have not heard of GVH of the brain in an autologous transplanted patient, but I have seen it implicated in allogeneic patients, again, as a diagnosis of exclusion, because I don't think, people are getting brain biopsies. I would say it's incredibly rare, and not much is known about it. I have not particularly heard of GVH involving the tympanic membrane, though.
Okay, here's a question, Dr. Steinberg. How can patients avoid worrying each time that they have a pain that their cancer might be coming back? What do you suggest to your patients?
Yeah, that's a really difficult question. I could just allude to it's kind of a little bit like personal experience. I had lymphoma when I was a senior in high school. I remember the first few years after my treatment, I didn't get a transplant, but my first years after treatment, I'd always feel a lymph node. Is this lymphoma? Is this not lymphoma? And then I'd rush to the doctor. And over time, you kind of the body will just gain experience a bit in terms of what this could be, what this might not be. But there's no easy answer, I would say, to that. I think provided you can have good follow-up with your doctor and periodic imaging, I think that would be an important extra support to you in terms of your concerns whenever you have certain pains. Yeah, but the first few years after transplants, it's definitely not an easy approach whenever you have symptoms.
Okay, we are going to be mindful of the panelists and the audience time, so this will have to be our last question. If there are no infections, is IVIG a treatment needed for post-CAR T and bacterium for myeloma patient on an ongoing basis to prevent infections due to suppressed immunity?
So I'm assuming that's for me. I'm next, huh? So yes. the answer is that the patients after CAR T cell therapy are markedly immune compromised based on three different things. One is they have underlying myeloma. And again, CAR T is only for patients who had 4 more lines of prior therapy, so they've had myeloma for a long time. Their immune systems have been exposed to multiple drugs, in addition to the fact that they have innate immune paresis because they have myeloma. Second is that they get lymphodepletion chemotherapy. They wipe out their one component of their immune system with the treatment of either fludarabine, cyclophosphamide, or bendamustine prior to getting the CAR T cells. And then the CAR T cells, in addition for the third insult, the CAR T cells themselves also cause immune suppression. So we have been putting the patients on Bactrim, and if their IgG levels are below 400, which most of them are, we've been putting them on monthly IVIG and Bactrim until their IgG levels over 400, which we already talked about previously, and until their immune parameters, it's called CD4 count, has exceeded 250. And when it hits that 250, then we discontinue the Bactrim. In general, this takes about 6 months for both the IgG to recover and for the CD4 count to recover.
Well, on behalf of BMT InfoNet and our partners, thank you, Dr. Phillips, Dr. Steinberg, and Dr. Vesole for your very helpful remarks. And thank you, the audience, for your excellent questions. Please let BMT InfoNet know if we can help in any way, and enjoy the rest of the symposium today.